I didn't realize that, I was like, I got myself all confused, I was so hung up on finishing on time, I was like, oh. And then somebody told me like, oh, you're supposed to go 2:45. It's like, well, too late to get everybody back, so we'll finish it. Yeah, I let y'all know at 2:15 last week.
I thought it was on purpose. I was like, oh, she's done for today.
I didn't know she did it on accident.
I was like, oh, thanks. Done for today.
You can make that accident again.
Oh, yeah.
First day.
I know, I was like, I was just so conscious of it, you know, and I was just like, I didn't wanna, whatever. But anyway, so it's fine, because this really does lend itself to our current discussion and what, like, some of the things we talked about this morning. And, so, you know, we ended last week with saying, okay, what do you wanna know with the assessment of pain, you know, and again, this is where your, you know, old carts or OPQRST really comes into play, and seeing what your patient's values are and, you know, what their pain tolerance is, okay? And sometimes it's realistic and sometimes it's not. I mean, sometimes we're not going to get people completely pain-free unless we put them on a propofol drip, you know, and completely sedate them and knock them out. And it's just not reality, okay? And so, all of those different characteristics are really what's going to, you know, clue you in as to where you need to be with your patient, okay? And yes, so managing pain it's a tangled web, okay? It's complicated, but it's not, you know, and it's really the people who are complicated, okay? And all of the different factors that enter into the pain experience. So, you know, I tend to always start with the, you know, the more, let's see, how we do this, the least, toxic, if you will, the most non-invasive techniques, obviously. And so, you know, we first want to kind of target, how do we stop the stimulation of those nociceptors, the nerve endings, that are specifically designed to treat pain, okay? And so, you know, Dr. Noel went over last week, even like capsaicin, which works. It works. So, you know, it may be an option. Lidocaine patches may very well, or, you know, the jelly may very well be a good option for certain types of pain. Is it going to affect the deep visceral pain? No, unfortunately not, okay? And so, you know, we have plenty of pharmacologic options, but we also have plenty of non-pharmacologic options, okay? The important thing is, especially for acute pain, we want to manage it aggressively, okay? Because we want to prevent that ongoing milieu of chemical messengers that set somebody up for a chronic pain syndrome, okay? And so, approach it aggressively, and hopefully we can alleviate it, get the patient on the right track, and prevent any type of chronic pain. Right? Chronic pain, on the other hand, there's so much that goes into the management of chronic pain. And what's the reason why narcotics aren't really your ideal in chronic pain? Pardon me?
Side effects.
Side effects, be specific.
Constipation.
No.
Okay.
It's chronic pain. Are we in?
Oh,
Go ahead,
addiction.
With chronic pain, you're gonna be a longer time, you know, when you're narcotic for a long time due to the pandemic.
Right, because of addiction. because of dependence, tolerance, and addiction. Yes. Okay? And yes, sometimes it's the only thing you're left with. Okay? But chronic pain, by definition, implies long-term treatment. And we know that if we treat somebody chronically with narcotics, there's going to be the development of tolerance, which means escalating doses. Okay? Which means the risk of, dependence, addiction, and then withdrawal symptoms when you can't get the medication. So, in this case, and in light of our morning's lecture, life expectancy also plays a role. Why do I say that? Kevin?
Because if someone's gonna die imminently, you don't wanna do something super invasive that's gonna cause them pain.
And what difference does it make if they become addicted or not?
Yeah.
They're imminently going to die. And so that's exactly the thought process, okay? So we do not withhold narcotics in those situations. The goal at that point is to keep the patient comfortable. So that helps you differentiate, some of these, which path to take, okay? So yeah, with chronic pain, we wanna prevent acute exacerbations, we wanna manage them, but we wanna kind of manage their ongoing pain as well, which often ends, when we talk about chronic pain, go back to what are the effects and what are the stimulators, okay? And so, sometimes, sometimes the antidepressants, the tricyclics, are the better choice. Because what's stimulating the pain at this point, what is stimulating those receptors? Serotonin, or we have these other neurotransmitters. So if we can affect change there, it's a better choice, okay, for long-term pain. So what's the cause? What's the natural history of the disease? And what's your patient's life expectancy? Is this a curable condition or is it incurable? So yeah, there's a whole host of interventions. We do nerve blocks. There's electrical there's, external units like TENS units, which, you put these electrodes on and they stimulate the nerve endings, and it's more of a distraction technique. But we also have implantable ones, okay, that work. There's therapy, there's cognitive behavioral interventions. And then, of course, we have our different pharmaceuticals, okay? And then there's some other, even depending on the condition, this is where, palliative radiation or palliative surgery to remove or resect an offending mass or something that's impinging on a nerve may actually be effective. Then you have acute pain, but you're removing the ultimate trigger of the pain. So, non-pharmacologic management, relaxation techniques, distraction, there's a couple different distraction techniques, imagery, and, really using the mind to escape, essentially, and not focus on the pain so much. There's biofeedback mechanisms, and that's not really the focus of this course, but note that all of these are just utilizing different neural pathways to essentially distract or, cause less tension or muscle spasm or, you know, different, you know, other stimulators of pain. So there are ways to do it, and then of course we talked about heat and cold, okay? And we know that heat is gonna vasodilate, so it's gonna increase capillary permeability, which is gonna increase the leak of your bradykinin, your prostaglandins, etc., into the milieu of chemical messengers, increase the migration of your white blood cells and inflammatory cells into the area. And so, which is going to stimulate more of your C fibers. Yes, it does encourage some of the release of your endogenous opioids. However, you know, there's other negative sides to it. Now, cold vasoconstricts, okay, which decreases the swelling in the area, which will decrease pressure on tissues. It can decrease the amount of chemical mediators in the area. It can be a competing knock to some of the other stimuli, and it also stimulates the release of endogenous opioids. So, really, this is why we alternate heat and cold sometimes. And even if you have an acute injury, you wanna use cold initially and then follow it up with heat, like a couple days later. So you use cold for the first 24, 48 hours, then you can apply heat, and it's complementary. So somehow, some way, there's a happy medium, okay? Like I said, some of these stimulus-induced analgesias, like the TENS unit, you see what it stands for, transcutaneous, versus neurostimulation, which is implantable, and then acupuncture, which is, needles into the skin type of thing to stimulate certain nerves, right? Your pharmacologic interventions, non-narcotics. This summarizes what Dr. Noel said last week, what aspirin's good for, what your NSAIDs are good for, what your acetaminophen is good for, right? As far as your opioids, okay? Your opioids, again, summarizes this. Realize that mu receptor is the more prevalent one, and so your mu receptors, modulate your pain, but also side effects. So, realize some of your side effects include respiratory depression, meiosis, the decreased gastrointestinal motility, which leads to the constipation, okay? And, but it also gives those feelings of well-being, euphoria, and it also creates the physical dependence. And these receptors are found both at pre- and postsynaptic sites in the dorsal horn of the spinal cord and also in the ascending pathways of the brainstem, the thalamus, and the cerebral cortex, as well as in the descending inhibitory system. So they're dispersed throughout where there are a lot of junctions of your first order, second order, and inhibitory pathway neurons. Okay? And we've talked about some of the adjuvant analgesics. And so he talked about the TCAs, he talked about the SSRIs, SNRIs, we have the antiepileptics, and even corticosteroids, okay? Sometimes corticosteroids can, because of their general anti-inflammatory effect, they can decrease inflammation in the area. Neuropathic pain, we know that has to do with damage or injury to a nerve per se, okay? And so it depends on the type of nerve. So, localized peripheral nerves, we usually think about entrapment syndromes like carpal tunnel, tarsal tunnel, ulnar tunnel. There are other nerve compressions that can occur either from tumors or scar tissue, and there's various neuralgias, as in post-herpetic neuralgia, etc. Okay? And so these are really localized regions of peripheral nerves. And so these often will respond well to some of those more localized treatments. and or surgical intervention. As far as wider or regional areas, we're talking about more systemic diseases like, diabetes, alcoholism, hypertension, and that complex regional pain syndrome. Phantom limb pain is a very special kind of pain, and it has to do with when you amputate, okay, a limb, you have to cut through all these structures, including the nerves, right? And so when you sever that nerve, sometimes the signals, the wiring in the brain still, when it's still the same nerve track, even though the peripheral end is gone. And so when that nerve track gets stimulated, patients perceive that the limb is still there, and it will result in what they call phantom limb pain. It's fascinating. All right, these are my references for the death and dying pathophys, which is not in your textbook, okay? And so there are two viable resources through the NIH database. Those of you who have experienced a dying patient, there are stages of active dying. Now, sometimes we know patients are going to die. They have a, terminal illness. However, there's a point where the scale tips into the active stages of dying, okay? And we tend to see it, the patients, in the early stages, there's early, middle, and late. The early stages, the patients become much less mobile, more bedbound, and they start to lose interest in eating and drinking. Okay. There are cognitive changes that occur. They sleep a lot more. They may experience a delirium, and that delirium can be either hyperactive or agitated, angry, or they can be hypoactive and less, like more withdrawn and less interactive. And it's just, there's a change, and it's a noticeable change in these patients, okay? That's really the early stages. Middle stage, you're gonna start to see a much more prominent decline in their mental status, and even to the point where they become slow to arouse, even obtunded, very brief periods of wakefulness. As they start to, lose control of their secretions, we start to hear what's called the death rattle as they breathe. And it sounds like their lungs are full of fluid, but it's just because they're not able to clear the secretions in their larger airways. And late stage is really when they become comatose. Sometimes they'll have a fever, and and a lot of times that could be due to aspirating and having an aspiration pneumonitis or pneumonia. And you will see alterations in their breathing patterns, including periods of apnea, where they'll breathe and then stop. They have that Shane-Stokes breathing pattern is pretty prognostic of imminent death. And as their circulation and vital organs start to shut down, their extremities will become more mottled appearing, pale, and clammy. What are some of the common symptoms? Pain is at the top of the list, and pain is what most people fear the most. Is they're more fearful of being in pain when they die than anything else. Dyspnea can be common, especially if they do aspirate. The delirium and agitation is pretty common. They can have nausea, vomiting, constipation. Again, they stop eating, they stop drinking, or very minimal. So nothing in means nothing out. And so all of their normal habits and being bedbound, it changes, you know, being that orthocolic reflex, when they get up and about in the morning and, you know, they have their normal bowel movements and things like that, you know, it's all stimulatory. But in this case, they're changing all their habits, they're laying in bed, and so without that movement, without that orthocolic reflex, you know, then they don't get that same stimulation to defecate. And so, you know, they will go days without having a bowel movement. And again, nothing in, nothing out. And you gotta realize that, and it's a point that we counsel our families on, regarding their, you know, their loved one. And then, of course, secretions and fever, which we've kind of talked about. So about half of your patients at the end of life will have pain in the last month. That's a reality, okay? And you've gotta recognize it, both physically and psychologically. Okay? And signs of distress, what do you think are signs of distress, even in a patient who's really not really communicative? Eliza? Facial expressions, look at their face, look at are they wincing, every time you move them, if you touch certain areas, you gotta look at facial expressions. What else? Pardon me? Accessory muscle use, because they're often, like, splinting their breathing, or breathing fast, or shallow. Mm-hmm. Their vitals can change if they have a lot of pain. Mm-hmm. So all of those things are important. And, you know, and at that point, this is where we want to help them with the euphoria, okay? We want to keep them pain-free, but we also want it to be in the dorsal horn, we want it to be in the periphery if they need it, we want it to be in the cerebral cortex, okay? We want to keep them comfortable. The dyspnea that we see at the end of life, what we see as, you know, dyspnea, shortness of breath, you know, you can see it in lung and heart disease, but you can also see it in cancer. Again, patients stop eating, they stop drinking, their body's breaking down your fats, you're utilizing fatty acids for metabolism. It's gonna increase your ketone load, so your keto acids, you become acidotic, you're gonna blow it off. So what we see as tachypnea may very well just be that they're trying to blow off their acid load, okay? And, you know, we see it in the cerebrovascular disease, dementia. Why? Because the brain controls our respiratory patterns. And as the function deteriorates and metabolically, it starts to go on autopilot and other alternative means of fuel for the cells, dysfunction occurs. So there's lots of reasons for it, but don't just rely on your pulse ox, okay? So pulse ox might be reading 98%, but your patient's going, you know, they're struggling, there's something's causing that. And a lot of times it is an acidosis. So look at that work of breathing. Make it more comfortable for them. Ease that struggle for the patient. Okay? And opioids do that. Okay? They suppress the respiratory drive. Does that mean you're killing your patient? No. You're just facilitating a normal process and making a patient comfortable. You are not killing your patient. A little bit more, if they're actually wheezing and they have lung disease, you can treat with bronchodilators if that's, absolutely, facilitate the breathing, okay? If they have fluid overload, yeah, if you need to, as long as it's not within if it's within their wishes, you give them diuretics. you control their heart rates. You can address these. This is all about advanced directives. Okay? Anxieties, we treat that as well. Be careful with benzos. How much did Professor Ohm tell you about benzos? Are they always anxiolytic? They're called anxiolytics, right? But they can have real serious paradoxical reactions, especially in dying patients. Okay? And so what we consider as an anxiolytic can actually cause them even more anxiety and exacerbate the problem and get them all ramped up and agitated. And you're like, well, I gave them Ativan. This is just, it happens. It just happens. Okay? So be careful with benzos, especially in your older patients. Utilize fans, like, circulate the air, breathing techniques, etc. Oxygen can or cannot be helpful. Has anybody here had to use oxygen before for anything? Okay, tell me about it. Was it comfortable? Did you like it?
No.
Why not?
Because you have this nasal cannula shoved up your nose and it's not comfy.
And it's blowing dry air, and it's
Yeah.
going, right?
Yeah.
And it's constant, and it's just drying out your nasal passages. And for some patients, it may actually feel like it's choking them. Lydia? Okay? And masks. I see patients claustrophobic, or they're confused. And all of a sudden, they've got this thing on their face, and they're having trouble breathing. What do you think they think? Somebody's suffocating them. They're suffocating. So what we think sometimes is helpful is not always helpful. So if we're at the end of life, opioids. Okay? Euphoria, relax that breathing, and make them comfortable. How about the delirium and agitation? Well, we talked about anxiolytics, okay? Again, they can be helpful, but beware of that paradoxical reaction, because you can get the exact opposite effect. Okay? Antipsychotics like your Haldol, haloperidol, that can be very helpful. Risperidone, they become, like, this risperidone has become more of a drug of choice in these situations. But sometimes you have to find out what the problem is. But it all has to do whether it's included in the advanced directives or not. If the patient doesn't want anything done, other than to be comfortable, don't do anything other than make them comfortable. Okay? Advanced directives tell you everything. All right, nausea and vomiting, it occurs. Okay, it can be, there's so many different, you remember the receptor pathway for nausea and vomiting, right? Vagal nerve and into the brainstem, and there's all these different tracks. Suggest you review these, but sometimes it's not about treating them with antiemetics. Sometimes it is. Sometimes motility agents help. If it's constipation, you gotta deal with the constipation. They haven't had a bowel movement in 5 days. You percuss their belly and, it's dull everywhere and they feel full. They're probably constipated. Especially if they've been eating even little bits. But you gotta monitor that. If there's nothing in, don't expect anything out. Fever and pressure ulcers. Okay, again, fever can be caused by, if it's a cancerous condition, it can be a paraneoplastic syndrome. It can be caused by infection, aspiration. If they have any kind of indwelling catheters, ports, etc., those things can get infected. Just monitor it. DVTs and PEs can also lead to fever. And if there's a reversible cause, obviously you want to treat that cause, but if it's not, simply treat with antipyretics. And bed sores are all about hypoperfusion to tissues, tissue breakdown. Okay? If it's not nourished, it's not getting oxygen, this compression, they're laying in the same position for 24 hours a day. All those bony prominences, they're putting pressure on those tissues underneath them. And so, you know, moving them, padding them, things like that to help promote circulation and blood flow to all those areas. It takes like less than 2 hours for tissue to start breaking down. Any questions on any of that?